Good morning, we're live.
Okay, great. Well, welcome everyone to the June meeting of the Health Policy Commission. I know we have two important projects to go over. But David, if you will, I understand that you and Colleen just came back from a very interesting meeting in Washington where a number of the states that are embarked on activities similar to ours took place. I wonder if you could share with my fellow commissioners and to the public here in Massachusetts what went on just quickly before we get officially into our meeting.
Sure, would be happy to, Mr. Chairman, and good afternoon, board members of the public. So Colleen and I were very pleased to participate in a meeting among states last week in Washington, D.C., hosted by the Peterson Foundation in collaboration with Milbank. The Peterson Foundation and Milbank have been supporting a cohort of states that have been pursuing healthcare cost growth benchmarks inspired by the Massachusetts Cost Containment Law, Chapter 224. So there are a number of states that have been participating for a few years, receiving technical support and assistance from the foundations. And as part of that, having opportunities to collaborate among the states and share lessons learned. Just sharing with commissioners, it was a very inspiring meeting. So many of these states are really building off of some of the great successes that we have achieved over the last 10 years. Just to give you a sense of the states that were involved include Washington, Oregon, Nevada, New Jersey, Delaware, Connecticut, and Rhode Island. So all of these states in one way or another are different stages of pursuing healthcare cost containment benchmarks and targets and associated strategies to reduce healthcare spending growth. So a really inspiring meeting, as I said, and an opportunity for us to learn from these other states as well, because some of these other states have really started to adopt even more tools and levers to be able to address healthcare cost growth and shift spending to primary care and behavioral healthcare spending. Colleen, anything that you'd like to share in reflections on the meeting last week?
Nothing really to add. I mean, it was honestly very interesting to be able to share the Massachusetts experience with the other states. They treat us like we are the seniors in high school and they sort of look up to us. But honestly, David and I's approach was to learn, and we took a lot away from the other states. And I think, as David said, just interesting that some of the states in some of their authorities are starting to surpass Massachusetts, even though we were the first to do many of these things. So we have a lot of good ideas, and a lot of them are already up on Beacon Hill in legislation that is moving. So we're hoping for some of that to pass.
Well, that's great. Thank you, David. Well, you know, it's I've been hearing it as well. It's first of all, it's nice to know that many parts of the country are looking to us. On the other hand, as you pointed out, some of them have leaped beyond us, and there may be some lessons we can learn from them. And maybe at some future time, you may want to sort of bring them in. And I'm sure some of the activities that they're involved in were in our recommendations on how we should proceed as well. Well, with that said, we can officially start the meeting. The first thing we need to do is approve the minutes. Since we are on Zoom, we have to do this by a roll call, and I have my trusted advisor here, Colleen Estamano, to take us through the minutes. So Colleen?
Absolutely. Do we have a motion to vote on the minutes?
So moved.
And a second?
Second.
Okay, we'll start with you, Chair Altman.
Approve.
Vice Chair Cohen.
Aye.
Commissioner Berwick.
Aye.
Commissioner Blakeney.
Aye.
Commissioner Cutler.
Aye.
Commissioner Haupt.
Aye.
And Commissioner Master Giovanni.
Aye.
Secretary Sutters.
Aye.
And Commissioner Roeder.
Aye.
Thank you very much.
All right, well, that's great. All right, David, now why don't you take us through how we're going to proceed for the remainder of this meeting.
Thank you, Mr. Chairman. As you said, we have two pretty meaty presentations and work to share with you. First, we're going to share findings from the upcoming healthcare cost trends report, our annual report. So Dr. David Auerbach will walk through a number of sections of that report in categories of our findings. That report will be released later this year. So this is really an opportunity for discussion and reflection on the findings and to help us as staff be able to craft the final report and to begin about thinking about both policy recommendations and also further areas of inquiry as we continue our research agenda. The second major presentation will be sharing evaluation findings from one of our recent investment programs focused on opioid use disorder. And so we'll walk through the findings that we have and the great results from that investment program. And then finally, I'll give just a brief executive director's report with some market oversight updates. But I think we can begin right away by diving into the findings from the cost trends report.
Okay.
Dr. David Auerbach, do you want to take it away?
Great. Yes, absolutely. Okay. So this, just before we get started, this slide is just going over the different sections of the cost trends report and keeping you up to date with where we are presenting and when the different parts of it. Today, we're going to be talking about the overall spending performance, which is the first chapter in the cost trends report, and then highlights from the chart packs, which we will go through one by one. As a reminder, about a month ago, we presented findings that will be in the main body of the cost trends report on changes in ambulatory care before and after and into the pandemic. And later in the next meeting, we're going to talk a bit about some of our dashboard findings as well as recommendations. Okay, so today's discussion will be in these four sections that you see here, starting with overall spending trends. Okay, so here's the big picture spending trend that we've been tracking. And of course, it's important to remember that a lot of what we're going to see is greatly affected by the COVID pandemic in 2020. Sometimes we'll be focusing on 2019 results just before the pandemic, and sometimes we'll take those out to 2021 where we can. But of course, that's in the background of a lot of what we're showing. So this is the overall spending growth trend compared to the overall US trend in the blue. And you can see that spending declined everywhere in 2020. We know that. And that in Massachusetts, the decline was a bit greater. And if you're curious, for the 10 years since 2010, where we have generally been below the US trend, our average spending growth has been 2.5% compared to 3.2 for the US in the blue. And that is a reversal from the first 10 years, 2000 to 2010, we were at 6.3% compared to 5.6 for the US. So 0.7 percentage points above to 0.7 below. Okay, next slide.
Wait, David, we just had already starting with the questions, which is
great.
great.
Oh, absolutely. Great. Yeah, please feel free to ask questions anywhere.
Oh, so David, I just want to ask, in some of the national data that we've seen, the national numbers are higher because of the federal payments that were made to organizations as part of, I think it was the CARES Act.
That's right. We took that out.
That's taken out of the national too?
Yep.
Okay.
And you wouldn't see it in the way that the way that GIA collects the data. We wouldn't see it here at all.
I really just wanted to make sure these were apples to apples because I knew we wouldn't see that. So I wanted to make sure that it would compromise.
Yeah, that's right. Because you probably remember some of the headlines were initially reporting from CMS that spending really jumped a lot in 2020. And that is if you include all that supplemental CARES Act funding. That's right. Okay. So on the next slide, we break down the 2020 the 19 to 20 trend in Massachusetts, according to the broad market sectors here, and really focus on the blue. The blue is the change in spending per enrollee or per member in that block. So per commercial member, average spending dropped 1.6% in 2020. And you see that the drops were higher for enrollees in Mass Health and in Medicare. So it ranges from a drop of 1.6% to about 4.7%. And really the reason that the commercial drop was less is because price increases were higher there. And we'll be talking about some of that throughout. I also want to just note at the end, we've been seeing year after year these enrollment shifts into Medicare Advantage, and that's happening nationally too. We used to have about 18.6% of our Medicare members in Medicare Advantage, and by 2020, it's up to about a quarter. And that is far below the national average, but it is still growing. Okay. And now we're showing just in the commercial sector, the Massachusetts and US trend. And you can see we had been below the US trend in growth in commercial spending since 2013, but that gap really closed in the latter half of this decade. And by 2020, our drop was a little smaller, so we grew a little bit faster. So really that differential has kind of eroded over time, and that's where we are. Okay. Now we're going to dive a little deeper into the commercial spending trends. We're showing 2018, 19, and 20 here with growth in the brackets above. And we've divided up commercial spending in a somewhat new way than we've done it before. Here, it's more like spending by setting of care. And we're including, where relevant, both facility spending in the dark blue and professional spending in the light blue. So you can see, for example, in the inpatient care, it's mostly facility spending, but there is also professional spending that we are including when it takes place. And so some of the broad things you see here, first of all, hospital outpatient department spending is the biggest category. It's by quite a lot. That's about a third of commercial spending occurs in that setting of care. And then looking at the drops from 2019 to 20, you see the big drop of 17% in the office setting, 14% in the ED, and not much of a drop in the inpatient setting. And within the HOPD category, the drop in the professional component was larger than overall. And then this is really in a big contrast to the pharmacy category, where we know from CHIA that actually grew in 2020, here by about 8.6%. So we'll dive a little more into these. Next slide.
David, really quickly, just had a Berwick.
Great.
I don't want to slow us down. Get back up one slide, please. So
Sure.
If you look at commercial spend or the total spend that you had earlier, since we're a high state in absolute spending, do we have a display, or could we someday see a display of what this graph would look like in dollars per capita over time, US versus Massachusetts, as opposed to just the rate of rise?
Yeah. Yes, we could do that. It would be dollars per commercial enrollee.
Well, given that the number of people who were working and therefore in the commercial fell during the COVID, the per person rate probably went up. I was going to ask that myself.
The per person. Well,
this is total commercial spending, right?
No, but this is per capita. So this is per person. So this is growth. Yeah. So this is growth year to year or change in commercial spending per enrollee.
All right. So the fact that the number of people in the commercial space is less, the total spending is actually falling further.
Mm-hmm. Mm-hmm. You get a sense of that if you flip back one more slide, just to show again what we did here. If you look in that commercial, we've divided that into spending per enrollee, which was down 1.6%, and the enrollees themselves were also down 2%. That's right. So the total commercial, dropped 3.6%. If you take it.
Thank you.
Yeah. Okay. And so,
Master Giovanni.
Yeah.
Thank you. I was just wondering, when we look at that breakdown, if you compare that at all to, on the previous slide, to the number of people in a high deductible policy, given the increase that we've been seeing on an annual basis in high deductibles and how much that has impact spending.
Yeah, and I didn't include that here today, but Chia tracks that fairly well, and that high deductible trend, it continues to grow every year from 18 to 19 to 20. And that probably has it has a small impact on spending. I think nationally, it's probably about the same trend.
Okay.
It's happening everywhere.
David, I have a quick question.
Yeah.
We have often cited CMS data that ranks all the different states on a per capita total healthcare spending basis. I think the last time that I saw that data was 2015, and we were ranked number 2 in terms of the highest total per capita healthcare spend of all the states. Do we have a sense of when we're going to get updated numbers on that particular analysis?
Any minute now. The last thing I heard was summer of 2022. Yeah, I'm waiting at the edge of our seats for the next block of CMS state data, which should bring us through 2019 when that is out. Yeah. Okay, I will let you know. Okay, so let's continue on. We have one slide where we're delving a little deeper into this large HOPD category. We wanted to understand some of the trends within that category, what was growing and what was falling. And so this is one subcategorization that we've used, and you can see all the components there. And we're showing total spending per person in 2018, 19, and 20. And what's interesting is the drops in 2020, the overall drop was really not uniform by these categories. Large drops in anesthesia, E&M, imaging, for example. But what's also interesting is the categories that did not drop. Chemotherapy and radiation oncology, for example, injections and infusions, they did not drop or even grew slightly in 2020. And we will be looking a little more into that. But given that they didn't drop, those two categories now make up about a quarter of all HOPD spending. It used to be about 20%. And we did a deep dive, UA did, on some of the top drugs in that injection and infusion category, the highest spending. And these are not included in pharmacy. This is within the HOPD category. It's the medical benefit. And the highest spending drug was called Ocrevus. It's an MS drug, and the cost per claim of that drug went up from $43,000 in 2019 to $46,000 in 2020. So that's 6% growth. So there is probably price growth as a component of why those categories did not drop in 2020, but we don't have the full story yet. Okay. The next several slides are diving a little deeper into that pharmacy category that grew 8.6%. Here we're breaking down over the last 4 years the share of all pharmacy spending made up by branded drugs. And the dark red is the share of all claims that are branded drugs. It's a minority. It's just 13 to 14%, but they're much more costly, of course. The share of all drug spending made up by branded drugs has grown from 78% to 83%. And even accounting for rebates, that share still is growing over time. So branded drugs are making up for more and more of total pharmacy spend. And on the next slide, we're showing some trends in the prices of those branded drugs. Again, from 2017 through 20, this is showing the distribution of prices of branded drugs per prescription. And so what you see is it's a very skewed distribution. In that shaded blue part, those are the prices of drugs that fall in the 25th to the 75th percentile. The orange dot is the average, and the average is way above the 75th percentile, which means this is a really driven by some very high cost drugs. And then on that right whisker is the 95th percentile. And you see all these averages are going up year after year, and that high 95th percentile is really going up. It's now over $5,000 per prescription is the 95th percentile of prescription drugs. And these price increases are really driven by a couple of things. It's growth in prices for existing branded drugs. And it's also the entry of new drugs, which have been entering at higher and higher prices each year. there was just a JAMA study just yesterday, which was really striking, showing that the average launch price of those drugs, the median, grew from about $1,300 in 2008 to $159,000 in 2021. Really, really striking increase in the launch price of those new branded drugs. Okay. And that's national. Okay, next slide. And then one more on the out-of-pocket spending for these drugs. We picked several categories that are dominated by mostly branded drugs for large numbers of patients who take them, and the average out-of-pocket spending for a 30-day supply of these categories of drugs has grown 40 to 50%, as you see there on the right, for these categories of prescription drugs. Okay, so that's the end of the spending section. Just I'll summarize a few of the key findings. Spending per enrollee declined everywhere, but the decline was from 1.6% for commercial to a 4.7% for those with mass health. Commercial spending declined for most categories, but not all. It was constant or slightly growing for cancer care, injections and infusions, and it grew for pharmacy. And that growth in pharmacy spending was driven by high prices for branded drugs. Average price grew from $684 in 2017 to $893 in 2020. Okay, let's go to the next section. Into the chart packs. The first one is the hospital and post-acute care utilization. Here is our hospital utilization trend per capita over the last 20 years. Dropped in 2020 everywhere, but we've maintained that about 7% higher rate of hospitalization in Massachusetts. And then we also can compare on the next slide, in addition to that inpatient trend on the top, hospital outpatient visits and ED visits. That gap that we've always had with the rest of the US is pretty much, it just holds steady. We have 42% more hospital outpatient visits and about 11% more ED visits. Next slide. Updating our readmission rates into 2020. You can see that in Medicare, which are the top two lines, Massachusetts in the orange and the US in the blue, we increased slightly while the US held steady. And so now we are the third highest state in terms of Medicare readmission rate in the country. And our all-payer readmissions also ticked up in 2020. And we also looked at on the next slide, kind of related, but preventable hospitalizations tracked by CMS. And here we were the fourth highest state in the rate of preventable hospitalizations for our Medicare beneficiaries, just those in Medicare fee-for-service. And you can see there, compared to the national average, quite a bit above.
David, we've been talking about this almost since we began.
I know.
And do we know any more?
Actually, Stuart, since we did begin.
Yeah, I remember that first meeting, Mary Lou.
Yep.
Have we learned anything? And we clearly have not had a big impact.
I don't know, honestly.
Well, join the group. And I remember the Beth Israel was really on top in terms of their readmission problem, and probably still is.
There's more detail, hospital by hospital in Chia's report, but I'm not sure where we are in terms of identifying solutions and making progress.
Don, you have a comment or a question?
Yeah, David, so this concept, preventable hospitalization, this is a very edgy slide. What's your degree of kind of confidence in the face validity of that concept? Have you developed a sense of confidence that these are in fact preventable and that we're not preventing them, or is there something else going on with our metric?
Yeah, that's a good question. It's like any measure like this, it's not perfect. It's tracked by CMS. It's through what they call these PQIs, quality indicators. And it's, as you can see in the notes, this is a combination of hospital admissions for a number of conditions: diabetes, COPD, asthma, hypertension, and so on. And so, I'm sure that they're probably not all technically preventable, but it's as close as a measure of that as we can get. And as to what's driving it, I don't have a lot of insight, beyond that, as to what's really behind it. Is it a higher propensity to hospitalize among a lot of things in Massachusetts, or is it, related to primary care or access or things like that? We could try to understand this better, but right now I don't have a lot of insight beyond it. Patty?
Is some of this just related to access to care? I mean, some of these states are more remote, hospitals are hundreds of miles away. People just aren't getting there for these treatments. And here in Massachusetts, I'm within the service area of at least 5 hospitals right where I live. So I think just being able to get there and get treated is a big part of this.
That could be a factor. Yeah. Okay. Let's keep going. Here we're tracking our ED boarding rate month by month. This is the percentage of ED visits where the patient ends up staying there for more than 12 hours. And we've shown this before in the orange. And this is just for all behavioral health related ED visits. But here we're doing one more thing is we can break those down. Most of those are either a mental health related visit or a substance use disorder related visit. And when you track those separately in the blue and the yellow, you see that it's really the mental health related visits that are driving that upward trend. And they have increased quite a lot in the rate of boarding from 37% in the beginning of 2019 to getting close to half by the end of 2021, where it's really the substance abuse visits have a lower rate of boarding, and that hasn't changed over time. So that was a helpful insight, and this was even discussed in the Globe just yesterday. Okay, next slide. And here we continue to track our discharges to post-acute care or other settings after a hospital stay. And we've noticed for years, this has continued, that fewer and fewer hospital stays are discharged to an institutional setting, which is good. And that dropped quite a bit in 2020 and then was fairly stable again in 2021. And so this is, again, continuing a long time trend. Now there are twice as many that are discharged to home health as to institutional settings. And we wanted to understand a little bit why that seemed to pause in 2021. And the next slide is kind of a fascinating look at that. We've known that part of that trend has been driven really by one DRG, one category of admission, which is hip and knee replacements. It's a large category, and the percentage of those discharged to institutional care has been dropping quite a lot over the years. In 2010, more than half of those types of operations those patients were sent to institutional settings, and that dropped, mostly going to home health. And then you can see, by 2020 and 21, it was about 82% of those going to home health. So that's a real switchover. And that in 2021, there was no change from 2020. So that seems that perhaps that shift has kind of completed as much as it can. But we were also struck on this slide by just the fact that the volume of these hospital visits did not come back in 2021. We know that during the height of the pandemic in spring of 2020, this was one of those elective admissions categories that almost went to zero in April of 2020. And I really thought that those would come back in 2021 as we reopened for discretionary admissions, and they continue to drop. So we'll be looking more at that, what happened. It's really puzzling. Some of them might have shifted to outpatient settings, but I don't know if that could account for all of that continued drop in 2021.
David, before we go too much further, if we could go back to the psychiatric slide, I think it was 3 slides ago.
Yes.
Do you have any sense from the data of what percentage of those patients are pediatric, young adult?
That's a good question.
I do. It's disproportionate kids.
Yeah. I know that the Globe reported on it again today.
Yeah.
Okay.
The Globe report is not.
No, it's not, but that it put it
But it is
right.
disproportionate to kids.
Yeah.
Okay.
And it's the impact of, I mean, you see the trend go up.
Yep.
It's the impact of practices, first of all, second to plastic surgery. The largest group that doesn't take insurance is behavioral health, right?
Okay.
So private practices. In fact, I just got the phone with a hospital outside of Boston, can't find resources for kids. They could find them if they paid privately, but not if
Okay.
but not if they took insurance. And I'm not talking just about Medicaid. I'm talking about commercial insurance. I see Marty nodding his head. And there's no question that the closure of schools and the impact of the pandemic on kids has created a lot of dysregulation in kids.
Mhm.
Exacerbated anxieties, depressions. I think we're going to probably have a whole new category of PTSD, COVID related, right? Anxieties, depression, the increase in etiology, and kids back in schools who've not had the structure of school for a while. And, there's a lot. We're going to be, the consequences of the pandemic on behavioral health are going to be years.
Years and years.
Yeah.
Thanks, Mary Lou. That's very helpful. Appreciate it.
And I can
I would-
actually, while we're on, I can actually get the percentage of, we don't use 12, we use the 12 hours, but we use like a different metric on kids who have been, or adults who've been in a hospital awaiting for an inpatient psych stay with the slightly different measure. So I can put that up. I'll say it because we're in a Zoom meeting. So
Thank you.
so
Okay.
I won't chat.
We could also do that. We could also do that breakdown later for you as well, if you want. Okay.
Thank you.
I would just add that the other impact here is the behavioral health workforce, which has, obviously taken beds and resources offline.
Mhm. I mean, the reality is in Massachusetts, we probably have sufficient physical capacity,
Yeah.
but on probably any given day, between 25 and 33% of the inpatient psychiatric beds are offline because of the staffing challenges.
Wow.
So David, if you go back to the last slide that you were showing about the hip and knees,
Yeah.
two things I would say. One, it may be a change in the whole practice of how the medical profession deals with these illnesses and do much more while they're inpatient, and therefore they don't need the post-acute. The other is the whole accountable care organizations really are designed to, in fact, look hard at the post-acute, because that's where they can save a lot of money by not doing it, or when they do it at home. So I think if we, to the extent that we have somewhat more accountable care, but I think it mainly must be a change in the practice of how the medical profession is dealing with these particular illnesses.
That's a good point. I would be curious to see how this differs for ACO, for hospitals and ACOs, for example. That might be interesting.
Yeah. Take a look at that. Okay, good.
Okay. Okay, good. I think we're into the next section. We have a finding summary. Third highest hospital readmission rate and the fourth highest rate of preventable hospitalizations. The percentage of mental health related ED visits that boarded grew to 45% by the end of 2021. And we saw that home health and institutional trend. Okay. The next section is the provider organization performance variation section. And we have a bunch here. Starting with total spending. And again, keep in mind, all the slides in this section are data for the collection of patients with primary care physicians in each of the named provider groups. And that's how it's assembled. So don't think hospitals necessarily. And here you see this continuing trend. Really, these are the 8 largest provider groups, and you can see that for most of them, the variation has actually condensed a bit from 2015 to 2020. They're all between 6,000 and 7,000 annual spending for the patients. And then you see the trend for MGB, which really has broken away from the other groups and is about 20% higher than the next highest spending group by 2020. And then in the next slide, so that was unadjusted total spending from all sources, everything, even including the non-claim spending. Now we're going into the claims data. And so we're able to adjust here for all sorts of things as we did here. The unadjusted is the blue, and this is not including prescription spending in this graph. Unadjusted in the blue, and then the adjusted in the orange. The adjusted differences are smaller. Here we're adjusting for patient risk scores and other characteristics. And keep in mind those risk scores they're not entirely a pure measure of health status, as we've shown. They can be influenced by the providers themselves. But in any case, the differences in spending can get a bit smaller when you look at the adjusted numbers, still with MGB the highest. Okay. Then we break down the spending trends by subcategory of spending. It's different than the categorization I showed before, but this is the more common one that's done, where that outpatient is only the facility spending, not the professional. The professional is all thrown into that yellow. So, but here the point is, as in previous years, that orange outpatient category is the most variant. It is driving most of the variation here. And it varies about more than 2 to 1 from MGH on the left to Reliant on the right. And
this is spending, so it includes both
yes,
price and quantity.
price and quantity. And we have prescription drugs included here also in the blue. Yes. And right. And that's actually that's a good point to make, because we will try to separate price and quantity a bit throughout the rest of this presentation to the extent that we can. The next slide is more of a quantity story. And what we're showing is we can look at a number of these services that could take place in a physician office, or they could take place in a hospital outpatient department. This is part of what's underneath the variation in that outpatient spending. Part of it is just site of care. These are substitutable services. They're labs and imaging and tests and things that could happen in both places. But when they happen in a HOP-D, they often come with a facility fee attached, and that can drive those differences. And here you see just a percentage of those crossover services that take place in a HOP-D based on what provider group you're in. And they vary a ton from in the 60s and 70s to as low as 15% for Reliant and Atrius, those groups that don't include hospitals in their system. So, and we're showing 2019 and 2020, pretty much the same story in both years. So these are structural differences. Okay. And then another measure that we compare across provider groups, ED visits, total ED visits in the light blue, potentially avoidable ones in the dark blue. And these vary, and similar to in prior years, the avoidable ED visits vary about 2 to 1 from top to bottom across these groups. Next slide. We also, as a new measure, we tracked total MRI and CT utilization across these groups. Some of this is potentially unnecessary utilization, but not all of it, of course. We adjust for patient risk scores and age, sex, other patient demographics as well as we can. And we find the variation is less here than in ED visits, for example, but there is still variation across these provider groups in utilization of these services. Okay. And now finally, a few slides on low value care, which we show every year. You can see the 9 services on the left, and total low value care, it did drop from 2019 to 2020, as we showed earlier. Number of patients with a low value care service dropped, but the variation across provider groups is fairly constant, still about 2 to 1 for most services. And we'll have a couple of slides on this detail.
David, before you move on, Professor Cutler had his hand raised.
Okay. Yep.
So David, I've just been thinking, this may be not directly addressed to you, but your comment that a lot of the difference between Mass General Brigham and the other organizations is in the use of HOPD for services that could be done in a physician's office, suggests that when we do talk about the performance improvement plan, that should be a part of that discussion. That is, what should that be a component, because we know that they're doing that much more than other things. So I think it's just worth putting that into, teeing that up for that discussion as well.
That makes sense to me. That, you know, that is one area where yes, there is discretion and there's the ability to do that shifting. And you know, the other solution is if there was site neutral payment and those payments were the same regardless of setting, then it wouldn't be as much of an issue. But there often is a payment differential. That's right.
Oh, but wait, yeah, but let's recognize that when the big centers, particularly Mass General Brigham, bring a physician group into their fold, what they wind up doing is not only do they technically bring them under their fold, but they often move them into to a setting which is part of their broader inpatient, outpatient.
Right.
So they become, by their very nature, that they're consciously doing A versus B. By doing C, they effectively create the inpatient or the in-institutional outpatient. And by doing that, they get facility fees and extra payments. So it is a costly venture.
Right. A lot of literature has found that in itself, this is
Well,
sometimes
we've been concerned.
a reason for consolidation, for vertical integration. Sorry.
Exactly.
Yeah. Okay. Great. Okay. Ready? Let's move on. Just a couple of examples of variation of some of the low value care measures we showed earlier. One of the larger categories here in terms of percent of patients that are given this low value care is in the orange. This is baseline labs that are often ordered before routine low risk surgeries. And what this is per 100 eligible patients. So these are rates that are between 20 and 30% in 2019 of patients being given these lab tests that are unnecessary. Vitamin D, oh, sorry, that's on the next slide. Let's move to the next slide. Here we have several screening tests, and I just want to note that vitamin D is one category that really has dropped in recent years. It used to be much more common routine vitamin D across the board testing, and it has dropped off quite a lot. There are higher rates for thyroid testing and stress testing still persisting. And on the next slide, we collected all of our 9 measures and added them up in terms of total spend on these 9 low value care measures per 100 patients. And the different provider groups are arrayed from left to right on that spending per 100 patients. And the size of the bubble is just the total number of attributed patients in the group. And you can see how those fall. Okay. Now I'd like to, summarizing that section, we saw these results differences in total spending. MGB has diverged from most of the other groups. Hospital outpatient spending varied from 2,600 per patient to just over 1,000. Part of the difference in that outpatient spending is this site of care setting of where patients are going for services that could be done in offices. Some variation in MRI and CT and in avoidable ED. And low value care variation across groups in that category as well. Okay. The final section is on prices, and towards the end, we're going to introduce a new price concept that I'll take a few minutes to explain. Let's get into it. Okay, first of all, we're tracking overall price growth for these 3 major categories of care, from 18 to 19 in the blue, and then 19 to 20 in the yellow. And so you can see that price growth has been lower in office settings, higher in the HOPD and the inpatient. And in the HOPD in particular, the price growth accelerated from 2019 to 2020, almost to 4%.
So David,
yeah.
Before you go on,
Sure.
what we're talking about here we're not talking about moving a patient from an outpatient office to an HOPD. We're talking about the actual prices within these categories, correct?
Exactly. That's right. And I should say this is only for commercial. This whole section is just for the commercial.
So the growth in spending
Yeah.
is greater than these because in addition to this, we have the actual movement from the office to the HOPD, which is what we talked about before.
Right. The growth in spending would be greater if you compound this with more volume. That's right. But of course, 2020 was weird and utilization dropped across the board. And so that's also going on in the background, but that's right. Yep. So these are overall aggregate price growth by sector, but we're going to dive a little deeper. Okay. And then a couple slides on coding trends coming up next. So again, remember that there's the price growth for a specific service, and then compounding that can be when visits and services are coded at higher and higher intensity levels. That's a separate factor driving spending growth. And here we're tracking that in the ED across years. And you can see, for example, these ED evaluation and management visits are coded level 1 through 5 and higher payments for level 5, of course. And the percentage of those visits coded at the highest level grew from 2017, 18, 19, and then grew quite a lot in 2020. And there's really a caveat there, again, with COVID, we saw a drop in a lot of avoidable ED visits. So there could have been a true increase in ED visit acuity in 2020. But nevertheless, there was a pre-existing trend of higher and higher severity codes for ED visits. And then on the next slide, we see the same trend on the inpatient side that we've been tracking year after year. Here going into 2020 and 21, the same trend. We've excluded the COVID stays. And you see that those level 4s used to be 4.4% of stays. Now they're up to 9.3 by 2021. And those are paid at a much higher rate than the other levels.
Which database are we looking at here? Is it all commercial?
This is all, yes, I'm sorry. Most of the slides in this section are just commercial, except for this one, I believe, which is all discharges across the entire state, all inpatient. Yeah. Okay. Next slide. Okay, so combining those trends together, now really back to just commercial though, and I'm just showing, we've shown this slide before, total spending per hospital admission all in, which is a consequence of the higher coded severity as well as the higher prices grew from about 14,000 to over 20,000 in 2020. Okay, so now we want to take a deeper dive into price trends, specifically in the hospital outpatient area. And what we're going to use is we're applying a common concept in economics called a market basket. And this is when you think of the inflation rate, which is tracked by the consumer price index, that's a market basket. What they do is they take a basket of goods and they just continue to ask, how much does it cost for this set of goods? And so as an example to explain what we're doing, you can think of it as, for example, I want to ask, how expensive is grocery store A versus grocery store B? One way to ask that question is I'm going to take a shopping list of items to grocery store A. And here I have an example shopping list. I'm going to get a gallon of milk, a dozen eggs, 5 pounds of rice. I buy all those things in grocery store A. And you can see there's my tally up the total spent, and it cost me $25 there. Then I take the same exact list of items, same quantities. I go to grocery store B. And some of the prices are higher and some of them are lower, but overall, for my same list, I'm spending $22.20 at grocery store B. So I will then say, all right, taken together, grocery store A is about 14% more expensive than grocery store B, assuming I'm happy with my list and I'm going to say it's representative of, things I might buy. Okay. On the next slide, we apply this concept to hospital outpatient departments. You could apply this to a lot of places across healthcare, but we started with the HOPD, which is a little hard to get your hands around because there's so many different things in a hospital outpatient department. And so here, as an example, we created a shopping list and we went to Beth Israel Medical Center in 2018, And you can see the items on this list: a screening mammography, colonoscopy, and so on. And in 2018, the average price at BidMIC for a screening mammography was $353. And let's say I bought six of those. So I spent $2,200 that year. Then I take my same list of services 2 years later, go to BidMIC again. How much did all of the things on my list cost? I find, okay, now it's $23,672. And I'm just showing an example here. I'll show more, but let's imagine I have 50 items on my grocery list. Then I can say, all right, the prices at that hospital outpatient department writ large increased by 5.6% across those 2 years. So this is the concept we're going to use. And the next slide gives a little more detail on how we actually constructed this. We brought together 50 items in our basket. And we chose the 50 items by just taking the top spending items from top to bottom and took the 50 highest spend. And you can see the top 10 here, but there's 40 more. The top spending HOPD item, it turns out, in 2018 was a screening mammography, 77067. Average cost of $290 per procedure, and so on. And then a colonoscopy, and then another colonoscopy, surgical pathology, an E&M visit, and then on down. Okay, so I take those 50 items, then I have to pick a quantity. How many do I want at each hospital? And I won't get into too much about how that is, but we came up with those by saying, what does an average 100 Massachusetts residents use in a year? How many of these things? So that I
not include professional fees. This is just the.
It does. Thanks for noting that. Actually, I forgot. Yep, we also included the professional fees. So it's all in. And for these top 10 items, you can see that now that screening mammography is accounting for about 8.1% of the weight in my basket, and then on down from there. So across the whole state, this shopping list of items cost $22,000 in 2018. So now I'm going to take that and I'm going to compare that. I can compare the same list across hospitals, which is on the next slide. And I think we're going to show hospitals in 2020. So in 2020, this is how much it would cost to buy the exact same set of items, the exact same quantities at each of the hospitals that had enough volume in Massachusetts. And here's that comparison. And you see that the variation is fairly large. It's about 2 to 1 from top to bottom, with a kind of a big tail on the left with some higher priced hospitals. We've coded some specialty hospitals in the dark blue, the AMCs in the orange, or the yellow really, and the teaching in the orange. And you see, as we see in other analyses, that the specialty hospitals, Children's and Dana-Farber, the island hospitals tend to have higher prices, but also some of the AMCs as well. Okay, let's keep going. So now we group those hospitals into these common cohorts, and you can see again, as a way to compare, the specialty hospitals had the highest prices for this quantity for this market basket of items, and also growing fairly quickly, 15.8% price growth between 2018 and 2020, with the teaching hospitals actually having the lowest prices in 2020 and in all the years. Okay. Something else we can do with this market basket concept is we can compare prices that the different payers are paying, which you can't do with the current relative price measure reported by CHIA, because those are all normed to each payer's own average. But here we can compare them, and this is kind of interesting. There is about 25% variation across the different payers. And this is not all the payers in the state. These are only the ones that we happen to capture currently in our extract of the APCD. But we are hoping once the full EAPCD is online, we'll be able to have a more comprehensive look by payer. Okay. And then we further break this down by hospital system. We've grouped the hospitals under the same corporate ownership. And you can see that the Cape Cod hospitals had the highest prices in both years. MGB is next, and then Berkshire with Bay State and Haywood, the lowest prices on the right. And in looking at it this way, we also saw there tended to be higher growth where there were also higher levels of prices. And so we looked at that in another way on the next graph. And that that trend, sorry, let's just go back one more. And so when you have higher levels also having higher growth, that means that the variation is expanding, the variation is increasing. And doing that calculation, you see that the variation was 47% in 2018, and that grew to 56% in 2020. So next slide is just another way to see that, where we have the price levels on the x-axis and the price growth on the y-axis, and the fact that there's an upward trend there, a diagonal from left to right, means that higher levels, the higher price places are also growing faster. And so they're diverging away from each other to some extent. And the circles here are just how big they are by volume. Okay. So we're at the end. So summarizing the findings from prices. Prices grew 1.5% in physician offices, but about 4% in both hospital settings. That HOPD price increase was an acceleration. Coded severity had continued to increase. The prices for our market basket of hospital outpatient services varied more than 2 to 1 by hospital. Highest at the specialty hospitals, the AMCs, the Cape Cod hospitals. And by system, we saw a somewhat divergence or increasing extent of price variation. And we hope to continue to talk about this concept and perhaps apply it to it could be easily applied to other categories of care or care for children or different subgroups. So we hope that'll be a useful way to think about prices in the future. Okay, are there any other questions on anything?
David, this is wonderful. I mean, the use of the all payer database, it's incredible, the detail. Thank you so much.
Great.
Any questions of my fellow commissioners? This was really, not only was insightful, but it was very clear. Keep it up.
Can I just,
Yeah.
I just want to try and summarize some of the, or maybe have David summarize some of the big points, because there were several sections of it.
Yep.
So there was a point about pharmaceutical pricing being very high at the high end and increasingly so. There was the point about doing a lot in hospital outpatient. There was a point about still having very high readmission rates. There was a point about prices, and they're going up more, particularly at the higher price places. And I guess I want to get a catalog of your top 4 or 5 things that you think we ought to pay attention to.
Yeah, I think you named them pretty well right there. We were trying to understand, because if you just look at the top line numbers, and you saw, 2020 total spending went down a little bit. There's really a lot of dynamics going on underneath that, and a lot of things that we will see, I'm sure, fairly high growth in 2021 when we come back. And these dynamics are things that are going to be driving that. And I think that you're right on the points about, variation in outpatient prices and this increase in that variation and divergence. There are things that can be done about, from a policy standpoint about setting of care. There are things that can be done about prices. The hospital avoidable admissions is really a hard one, and I don't have a good handle on that, but I think it's important to keep pointing out, we do well in a lot of things in Massachusetts, and I don't always show the things that we do well at, but I don't mean to say that we're terrible across the board, but we just tend to highlight, it's important to highlight where we could improve, and that's really the point. And there is variation across provider groups on so many different measures that we've shown, and a lot of that persists year after year. And I'm really glad one provider organization called us up recently and said, look, we want to improve. We looked into some of our own data that you were showing and trying to replicate that. And, can you help us figure out what's going on? And I think that's fantastic. I think that's very helpful.
That's great. Barbara?
Thank you. David, I just want to join in the complimenting you and your staff for this work. It gives us a rich database from which to do continued analysis. And I look forward to hearing from you and your staff what we're going to do with all this data and how we're going to mine it, how we're going to make sure it has the most impact we can possibly create. So thank you. It's very, very rich. Appreciate it.
Thank you.
Don?
I add my kudos first, David. You continue to just blow me away with what you're able to do with numbers. I have two comments. In the dialogue of the nation, we often use the term value, value-based purchasing, value-based stuff, and it's been very elusive. I can't help wondering if now, given the array of characterizations you're able to offer of hospitals or of plans or of groups, if we aren't getting close to being able to do some scoring of value, institution by institution. What's the highest value hospital in the Commonwealth right now? What's the, is that a stupid question, or is there a way to explore it? I think there may be something in that, and be happy to help offline to think that through. That's number one. Now, related to that, I have maybe a sort of an edgy comment that I'd like to put on the parking lot, which is, if I think eyeballing this, if you look at value, Atrius Health emerges over and over again as a high value place. Very good performance on the quality parameters, very low cost on a lot of the cost parameters, I think, and yet they got into trouble. I'd like to know why. That is, or maybe a broader form of the question is our Commonwealth rewarding value among the delivery systems and plans or not? And I don't know the story there, but I'd sure love to be able to dig into it.
Good comment. Marty?
Yeah, thanks, Stuart. Kudos, David, as well on the wonderful work. I want to pick up on something you just said, where you said a hospital reached out to you to try to understand their data better. Mm-hmm. And, while we publish this in the cost trends report, I'm wondering if we should be doing more, not waiting for the hospitals to come to us, but reaching out to them, maybe bringing clinical leadership of certain hospitals together to talk about issues like low value care, where we've identified clearly that they lag in certain areas, not waiting for a performance improvement plan, but really sort of taking these data and working with the leadership of these hospitals in different ways to try to address some of these issues.
Marty, that's an excellent example. And I would put high on that list, that issue about readmissions. Ron?
Yeah, David, very impressive job. In looking at some of the charts, and we look at the specialty hospitals and the cost growth within those hospitals, if we compared that to some of the larger institutions like Leahy and MGHB, and we compared the increase in costs in comparison to that specialty area, how do those costs differ? Have you looked at that?
Here we're comparing apples to apples of the prices for these, these 50 services. If you wanted to know how much it's a hard concept. It's a hard concept, like how do I get a good comparison of, someone at Children's Hospital, for example, to others. And so it's hard to do. So one thought we have is we could take something like this market basket, but instead look at just care for a set of children, perhaps children with a chronic condition, and find all the services that they tend to use and compare, provider group by provider group or hospital by hospital as a way to kind of drill down a little bit to get at these larger, what is the total cost? Because I think that is the key question. It's hard to get a handle on total cost. The price of this basket is one piece of it, but there's more than that. There's quantities, there's volume, there's care management, there's a lot more to it. And so that's the $1 million question, but I think we can do a little better and triangulate towards that with some additional work, and we will try to do that.
Well, again, that was great, and I look forward to hearing more about it. So let me turn the program back to David to take us to the next issue. David?
Thank you. Thank you, Mr. Chairman. Thank you, commissioners, for the great questions and comments throughout. A lot of really good ideas there. And thank you, David, and the research and cost trends team. Excellent work. So we're going to pivot for the second half of the meeting to our investment team and our healthcare innovation team, and really want to be able to share overall findings of one of our more recent investment programs. And I think to kind of pivot away from the cost trends report to the investment work that we do, here we are working very directly with hospitals and healthcare providers to work together to improve patient care, to reduce costs in a very direct way. And so this was a program that you'll hear about that was really responsive to the opioid disorder crisis in Massachusetts, building off of a nationally recognized model that we were able to implement at a number of institutions across the Commonwealth. And so very excited to turn it over to Kelly Hall to introduce this topic and to share some of the findings from this grant program.
Thank you so much, David, and good afternoon, commissioners. As David said, just by way of a bit of introduction, in 2018, as David noted, responding to a critical need for options for treatment for opioid use disorder, the legislature directed the HPC to implement a pilot program dedicated specifically to expanding access to OUD treatment by initiating medication for addiction treatment in the emergency department. That program became one of two tracks in the Sustainable Healthcare Innovations Fostering Transformation, or Shift Care Challenge. So as David said, we're here today to reorient you to the key elements of the Shift Care opioid use disorder track and share findings from an external evaluation conducted by teams from Brandeis University. So before we go on, let me just note, for better or for worse, the Shift Care program implementation period overlapped some of the most intense periods of the COVID-19 pandemic. I say for worse because COVID-related disruptions undoubtedly created challenges for awardees in their implementations and complicated some aspects of data collection and measurement. And I also say for better because our awardees showed considerable adaptability and resilience in finding ways to continue to provide treatment and critical wraparound services for patients, despite myriad complications presented by the pandemic. So today, Taylor Bungo, an associate director on the Healthcare Transformation and Innovation team, and the program manager for the Shift Care program will share results from the evaluation, highlighting both quantitative impact, important qualitative findings, and valuable lessons that emerged from the program. Following that presentation, we are also going to share a short video developed by our learning and dissemination team that tells the story of this program, and particularly the critical role of peer recovery coaches from the perspective of the people who matter most, the patients and the caregivers who benefited directly from the HPC's investment. So with that, let me turn it over to Taylor.
Thank you, Kelly, and good afternoon, commissioners. I'm really excited to share part of the Shift Care story with you today. As Kelly mentioned, this program is special to me, not only because I had the opportunity to oversee it, but also because it was one that ran during the height of a global pandemic, which compounded the very issues that our awardees were trying to tackle. And while commitment to patient care in the midst of a pandemic is commendable on its own, this cohort truly went above and beyond to achieve some impressive results that I'm excited to share with you today. So in January of 2018, the HPC issued a request for proposals for the Shift Care Challenge, which was an opportunity to implement an innovative care model to address whole person needs. So Shift Care had two tracks, as Kelly mentioned. One was dedicated to addressing health-related social needs, and the other was dedicated to addressing timely access to behavioral health. Within the behavioral health care track, there were 9 awardees that were focused on addressing opioid use disorder. And so those are the 9 awardees that we're going to discuss today. Next slide, please. In Section 178, Chapter 133 of the Acts of 2016, the Massachusetts legislature appropriated funds to support medication for addiction treatment for opioid use disorder. The program would require use of an evidence-based model for initiating medication for addiction treatment in the emergency department, with the goal of increasing rates of patient engagement and retention in treatment. Next slide. After a very competitive review process, the board approved 15 awards for the Shift Care program. And as you can see here, the recipients reflect the geographic diversity of Massachusetts. The 9 awardees in orange represent those programs focused on OUD, and again, those are the ones we're going to talk about today. Next slide, please. So here's a list of the 9 awardees in the OUD track, as well as their award amounts. And as Kelly said, Shift Care stands for Sustainable Healthcare Innovations, Fostering Transformative Care. So we wanted to structure this program to reinforce our emphasis on sustainability. And to that end, we required each awardee to have a 25% in-kind investment from their own organizations. You can see those amounts listed on the slide, and then to the right of it, you'll see the remaining 75% of the total investment that came from the HPC. Next slide. As you may recall from the legislative language earlier, the program would require use of an evidence-based approach. And so as part of the RFP package, we provided an example of an evidence-based model from Yale New Haven Hospital. So on this slide here, you can see a treatment model that is similar to Yale New Haven's and also similar to what most awardees used for their Shift Care programs. So this created a really unique opportunity for the Shift Care OUD track because we had 9 different hospitals across Massachusetts implementing the same type of MAT model. And while there were a few notable variations across the 9 awardees, most models shared these components. So first, patients with a history of OUD or experiencing an overdose are identified in the emergency department. Patients meet with a recovery coach or addiction consult team in the emergency department to make a connection and are given the opportunity to start medication for addiction treatment. A qualified prescriber initiates MAT, and then the patient is discharged with a follow-up appointment within 72 hours. Next slide. So the Yale model shown on the previous slide doesn't address every component of the care models that awardees considered when designing their own programs. So here you have a more granular picture of the key features of the programs. You'll notice in the shaded areas that there is consistency across all 9 awardees in some of these components. So for example, nearly all awardees had real-time identification of patients in the emergency department. Nearly all used recovery coaches, and nearly all provided take-home kits for MAT when appropriate. In the non-shaded rows, awardees customized their care models to fit their own organization's needs and priorities. Next slide. So as I mentioned earlier, the consistencies across the 9 awardee models provided us with a unique opportunity to look at cohort-wide impact. So we wanted to know, did the program have an impact on the rate of MAT initiation? Did patients who started treatment stay in treatment? Did initiation rates have an impact on hospitalizations or mortality? And how did providers feel about the program and the elements that were successful? And how did the patients experience the program? What you'll see on the following slides, and the main point I want you to take away from the presentation, is that despite a pandemic, this cohort achieved positive results in our initiation and engagement and retention rates. And while the data on hospitalizations, mortality, and overdose tell a more complicated story, this was a largely really successful program. And the qualitative data also provides some rich insight into how the program's achieved success overall. So on this slide, you can see that we contracted with a third-party evaluator, Brandeis University, to conduct the evaluation. And Brandeis used a mixed methods quality improvement approach. So it was aimed at improving practice rather than developing research insights. There was a quantitative portion of the evaluation that explored rates of ED initiation, engagement in treatment, retention, revisits, hospitalization, mortality, and overdose rates. And then the qualitative portion used document review from awardee updates, as well as structured conversations with nearly 50 patients and 35 staff, most of whom also had lived experience. For the next few slides, we'll walk through some of the quantitative and qualitative findings from the program in more detail. Next slide. So over the course of the Shift Care program, the rate of initiation of MAT doubled. So during baseline assessment, the average initiation rate across the cohort was 5.8%, and during the intervention period, the rate was statistically higher at 11.6%, suggesting that the Shift Care program did positively impact the rate of MAT initiation across the cohort. These numbers, again, are quite impressive, especially in the midst of a pandemic. Next slide, please. So another variable we were interested in was the rate of engagement from patients in the program. So said another way, once patients initiated MAT, did they remain engaged in their treatment through their visits and continued medication use? If you look at the x-axis at the bottom of the graph, you can see that we measured engagement in treatment at multiple time points. So did patients remain engaged at 30 days, 60 days, 90 days, all the way through 180 days? The average engagement rate for all patients at 30 days was 45%. However, please note that the graph reflects data among patients with 6 months of follow-up time. So the rate reflected on the graph is a little higher at 47%. As we get further away from the day of initiation, the rates of engagement drop a little bit and then flatten out around 30% by 180 days. The rates are comparable to other studies and may actually be an underestimate. Hospitals were able to keep tabs on patients who connected to ongoing treatment within their network of providers or partners, but they may have missed some of the connections made outside of that scope. Next slide. So we also wanted to take a look at utilization and Shift Care and whether Shift Care had an impact on the rate of ED revisits. So did patients who had an initial visit in the emergency department and received MAT return to the ED within 30 days? Ultimately, we found that while the 30-day ED revisit rate declined over time, the difference between the revisit rate for patients who were initiated and patients who were not was not statistically different. But again, there are a couple of contextual factors that are important to remember as we interpret these findings. One, again, the Shift Care program was running during the height of the COVID pandemic, which may have impacted utilization here. And two, the point of the program was to initiate patients in treatment and then keep them engaged. So it's possible that repeat ED visits could indicate a positive treatment trajectory. If patients had a positive experience in the ED and knew that treatment was available there, they may be more likely to return to that site for care, especially if they had few other connections to the healthcare system. So again, utilization is a complicated story. Next slide. This table shows the impact on hospitalizations, mortality, and both fatal and non-fatal overdose. So ultimately, there was no statistically significant difference found in ED visits, mortality, fatal overdose, and non-fatal overdose between baseline and intervention periods, or between those who were initiated on MAT through Shift Care and those who were not. Again, the impact of the pandemic makes this data really tough to interpret. In addition, mortality and overdose rates are really small numbers and reflect a composite of DPH and hospital data, so it's difficult to interpret. You'll see at the top, there's some asterisks that indicate the rate of hospitalizations was significantly lower during Shift Care when compared to the baseline period. However, as you continue to look across that line, you'll note that the rate of hospitalizations was actually lower among those who were not initiated on MAT. Again, we want to be cautious when drawing conclusions from these data because of the massive impact that COVID may have had on utilization rates at the time. Next slide. So now we're going to transition to some of the qualitative findings that you see listed here. Next slide, please. So in addition to looking at the quantitative outcomes of interest, we wanted to better understand how these programs were implemented and what we could learn about what worked well and what didn't. One of the main things we heard from Shift Care staff was how critical it was to gain buy-in from ED leadership in order to have success in implementing these new protocols to dispense MAT in the ED. In addition, awardees found that implementing this program successfully also required coordination from other hospital staff, including nursing, pharmacy, and IT, among others. Gaining buy-in from these groups, including the ED, required in-service training and education about the Shift Care program and opioid use disorder specifically. Some awardees found that co-locating addiction consult teams in the ED with more specialized behavioral health training was a great resource to ED providers treating patients with addiction. Next slide. Relatedly, Shift Care staff identified stigma as a major barrier to gaining buy-in to the program. Not only did ED physicians and staff hold biases around addiction and around using medication for addiction treatment, but patients also held stigma. So there was stigma happening at multiple levels here. In fact, awardees stated that changing the culture and specifically reducing stigma around addiction and the use of MAT was one of the biggest changes they perceived as a result of the Shift Care program. By the end of the program, ED environments were changing. So this is important because those ED cultures that used to impede a patient's ability to begin their recovery were now actually facilitating it. And patients who held self-limiting beliefs about how addiction was a personal failing were changing their understanding of themselves and their hope for the future. Next slide. Another large part of what made this transition in culture possible was the presence of recovery coaches as part of the care team. Recovery coaches are staff with lived experience of addiction that make meaningful connections with patients and support them on their recovery journey. Nearly every awardee used recovery coaches as part of their program, and they became an incredibly valuable resource for each team. ED staff were grateful to have recovery coaches meet with patients during their visit because they could forge connections with patients in a way that staff without lived experience could not. And patients found hope in hearing from recovery coaches because they could relate to the patient's challenges, offer pathways to recovery, and ultimately help them rebuild trust in the medical system. Even if patients didn't choose to initiate treatment the first, the second, or even the third time they met with a recovery coach, staff with lived experience believed that this point of connection was an important way to at least spark readiness for a future encounter. Next slide. Another important finding that emerged from the program is the necessity of a network of resources to support the patient in their recovery. Through our interviews, we found that patients showing up with OUD in the ED had really complex medical, economic, and social histories, all of which affected the patient's ability to engage or remain in treatment. As a result, many awardees found that hospital services alone were insufficient to address all of these issues. As one Shift Care staff member said, our patients need so much. Yes, medication, along with trauma and mental health care, access to a range of credible treatment options, and they must have a way to access avenues off the streets, housing, food, work, activities if they can't work, and sober support. Next slide. Connecting patients to community-based services became incredibly valuable to facilitate retention and treatment. Patients experiencing OUD who end up in the ED are often in a really vulnerable place with many urgent needs. Awardees learned that providers actually feel more comfortable prescribing MAT to patients if they know that their patient will receive follow-up care from another team. A number of awardees used bridge clinics or sites that provide short-term outpatient treatment to quote-unquote bridge the gap between MAT initiation and connections to community-based care. Shift Care teams forged meaningful relationships with PCPs, detox centers, outpatient facilities, and community organizations that help address health-related social needs to ensure wraparound services for patients. Next slide. Finally, awardees also had some reflections on the feasibility of the emergency department as a site for initiating MAT. At the end of the day, people experiencing opioid use disorder will continue to show up in the ED because it is an easy access point for care, and sometimes the patient's only point of access for the entire healthcare system. So many awardees agreed that it's important for the ED to be equipped to begin medication for addiction treatment for those who show up. However, as we discussed earlier, there are a lot of challenges to doing this work in the ED. Stigma, long wait times, and competing priorities make the ED a difficult environment to treat behavioral health issues. And most awardees agreed that the ED is an important piece to the puzzle, but that it should only be one component of a broader systemic effort to provide access to MAT. Next slide. At the end of the day, we're really excited to share that all awardees are planning to continue, or in some cases even expand their shift care program. For example, the Healing Community Study, a partnership between the NIH, Boston Medical Center, and hospitals across Massachusetts, is funding nearly half of the shift care awardees in continuing their shift care programs in whole or in part. Awardees found great value in the role of recovery coaches, and many are finding additional funding to continue those roles. Major cultural shifts have occurred as a result of this program through education, in-services, and anti-stigma efforts. Awardees saw an increase in willingness to prescribe buprenorphine, a reduction in stigma, and an increase in buy-in, and these shifts are likely to continue beyond the grant period. In some cases, awardees have found additional funding to expand on their original models, investing in additional addiction staff or partnerships to support patient care. Next slide, please. So obviously, there are a lot of really great outcomes here and insights from this program, and we're excited to have a number of learning and dissemination outputs in the works that will share what we've learned. If you're interested in learning more about the details of the evaluation that I highlighted today, you can check out the full Brandeis University evaluation report that will be posted on our website. We also just released a case study of Harrington's OUD program, and we will be releasing an impact brief for the OUD cohort shortly. We also are interested in hosting a webinar that focuses more on the strategies and approaches behind this work, and hopefully would feature some of the awardee staff themselves telling their shift care story. In addition, we're analyzing and synthesizing the data from the other track of our shift care program, the health-related social needs cohort, and we'll be releasing a separate evaluation report on those programs in the coming months. So thank you, commissioners and the public, for listening to this presentation, and I'm happy to answer any follow-up questions that you may have about the shift care program before we see the video.
Hey, Taylor, that was fantastic. What a great presentation. All right, let me turn it over to the commissioners for questions or comments. Anybody? Marty, this is your world. What do you think?
Yeah, Taylor, great job. Wonderful, wonderful outcomes, and so happy to see that this work is continuing. My question was actually going to be on the dissemination strategy, which you just articulated well. I think the more we can do either through webinars or even at face-to-face meetings to share this result with hospitals and ED administrators throughout the state, I think would be well advised.
Thanks so much, Commissioner Cohen. I completely agree, and I think that's why the prospects of something like a webinar are really exciting, because it's hard, even for me as someone who managed the program, to really articulate all of the insights and learnings that our staff on the ground were able to learn about. So I look forward to coming up with some more ideas like that.
Madam Secretary, this is a world that you've lived in for many years.
Yeah, it's interesting. I'm assuming you've collaborated with the Department of Public Health. The thing on the inpatient is, does that include the Section 35s? So that does not usually run through hospitals. So that would actually deviate, that would probably obscure some of your data.
Great.
That's great.
Because people are not generally hospitalized for substance use disorder.
Right.
But it's, recovery coaches. We've been a huge supporter of having recovery coaches in emergency departments as a way to really connect. And it's nice to see that highlighted in this report. Unfortunately, only Medicaid actually covers that. Something that we've been trying to extend throughout the Commonwealth.
Great.
But it's, as she pointed out, like connecting, the connective tissue is an environment that is supportive, non-judgmental, and
absolutely
can connect with someone in that moment, right? And
absolutely.
your comment about leadership is is so taken. So appreciate that.
All right, thank you.
Thank
David?
you.
So I thought that was fascinating, and I thought it was really well done. I want to ask one question that I don't think is the most important one, but I just want to see if you have an answer.
Sure.
Which is there, if you look not at the patient's health, which is obviously the most important thing, but at the dollars here, did Brandeis make a guess as to whether this saved money? So that is, it's absolutely clearly improving people's health. The question is it also saving the Commonwealth money or not? And I'm curious about the answer to that.
Yeah, so Brandeis did not do a cost analysis as part of this evaluation. I will say the Yale model that I referenced earlier did evaluate that and concluded that there is a cost effectiveness to initiating medication for addiction treatment in the emergency department as opposed to simply like an expert and a referral to community resources. But within the context of this program, that was not something that was analyzed.
Other questions or comments?
May I, Stuart, first for a second?
Please.
I just want to piggyback on something that David Cutler said, because it's been sort of a theme I've had for a while on these kinds of pilots. One of the things that makes HPC unique and not another form of the Department of Public Health, if you would, is in fact both the intervention, the outcome, as well as the cost effectiveness, right? Health Policy Commission, right? It's about how do we manage our costs. And I would encourage that when we do evaluations that we in fact insist that there be a cost, some kind of cost benefit, cost effectiveness, a cost something, so that, right, it becomes part of the potential replication in the Commonwealth.
Absolutely. Thank you for that feedback.
Okay. All right.
Can I just say, Stuart, I just want to add my thanks to the staff for doing this. I noticed that the southeastern part of the state was not really represented in the initial cohort, and that's an area of quite a bit of a hot spot with respect to some of what we're talking about. And I hope we can extend some help and lessons down to that part of the state, as well as other parts that were not able to be grantees.
Yeah, that would be a great opportunity for our learning and dissemination work to connect with other parts of the state that weren't awarded this time around.
All right. All right, let me turn the program back to David for your executive director's report.
Before we jump into the executive director's report, though, we did work on a video just highlighting some of the
yes, I want to see the video
challenge. So Taylor, do you want to introduce the video quickly?
Sure.
Yes. So this video, thanks to the UMass team, we have a look inside their Shift Care award experience, and I'll let the video do the rest of the talking.
Thank you.
Don't think we have sound.
The opioid epidemic has affected my community in a lot of different ways. It's a tragedy.
No one should die from an opioid-related overdose. We know how to intervene and save someone's life. We know how to treat the underlying condition of opioid use disorder. So it's really an example of how we haven't had the will to mount a response that meets the needs of the current crisis.
The Shift Care program was offered as a challenge to clinical systems throughout the state to see if we could do better vis-a-vis patients with opioid use disorders that were presenting in the hospital.
Funding supported 9 hospitals to be able to offer immediate access to medication treatment for opioid use disorder in the emergency department, link people to ongoing care and bridge clinics, and to build in peer recovery coaches as a part of the healthcare team.
But what wasn't working is that we weren't reaching the patients where they were at. And where they're at is in crisis. And that's where the bridge-in clinic and our approach, meeting them right in the emergency room and saying, you can come and see us today, tomorrow, right now.
The idea was to give those patients easy access to treatment, quick access, and a quick referral to outpatient services. Whatever work was started in the emergency room, we were able to pick up on outpatient basis and work with those patients in the community.
When I got to the ER, I just knew that I was at the end of my deck. I got hooked up with a real good doctor that day, and I was able to tell him everything and be honest with him about my drug use and my addiction. He was just the nicest person. 1, he made it easy for me, and 2, he didn't judge me. And from there, it just was golden, I'd say.
Our patients are very much the ones that fell through the system. We see people that are at their lowest low, and oftentimes we forget that there's a person in there that has so much to offer. They just want hope, and there's nothing in this world that can change their mind outside of somebody caring.
I feel like with Brian in particular, he didn't make me feel uncomfortable, he didn't judge me. With somebody that you know that's been through it, and they can give you real insight, advice, they can relate to almost anything you say, and they can also help you come up with a solution at the same time, all while not judging you. I feel like that's a recipe for success.
My role as a recovery coach is to meet with a patient and work with them on a peer basis in order to help figure out what social barriers are preventing them from a successful recovery.
Bringing in peer recovery coaches has been hugely transformative. We often talk about them as being the human glue of the work that we do, because not only do they provide invaluable care to patients, but they also are sort of a living, breathing reminder every day that most people recover.
The difference that they make is that they're in recovery themselves. They've been in recovery for more than a year, and they have been trained to be able to help their peers.
Here, we bring our coaches in as full employees, fully trained and oriented to hospital practices, and yet they retain this other special contribution in their awareness of our community and what it means to live with these problems.
A doctor's always going to tell them, just take this medicine and you'll feel better. They know what's available, but if they have their peers that are on their level telling them, they listen.
I can recall back to that day where I had Suboxone in my left hand and I had two pills of oxycodone in my right hand, and I decided to go with the medication, and from there it's been quite a journey. And I remember texting Brian roughly about an hour or 2 hours after, and thanking him that I felt like that was just the start of it, and I felt like that was my breakthrough moment.
Sometimes I can get people to talk to me that wouldn't normally engage with anybody in the medical community. And if I can break down that barrier this week, then who knows what will happen in the months to come, years to come.
A lot of patients say, this is the first time I feel like I can do this. This is the first time that I feel like maybe, just maybe, I won't die. We can do this. We can creatively respond to a public health crisis and meet the needs of people across the full sort of spectrum of who they are. And the real need is that we have the will to do that in the context of overdose. I don't think we're ever going to cure or eradicate addiction, but I think we're going to see far less overdoses. And for every person that doesn't end as another fatal overdose is another person that is potentially getting their life back.
So a final thank you to our awardees in this Shift Care Challenge, and as highlighted there at UMass, a great video highlighting the important role of peer recovery coaches in particular. Thank you, commissioners, for your attention and feedback on the Shift Care Challenge. I think Commissioner Chair Altman, if you're ready, we can move into the final agenda item, which is the Executive Director's report.
Yes, absolutely, David. Thank you.
Great. Thank you. So I will be leading the Executive Director's report today. And as part of that, going through the market changes update, which typically members of our market oversight team prepare for you. But I will soldier through and rely on them if there are questions along the way. So first, our standard tracker. Since the Health Policy Commission was established, we've received notice of 141 provider transactions, with formations of contracting entities being the most frequent, followed by physician group transactions and clinical affiliations. On the next slide, since our last board meeting, the HPC has elected not to proceed with a cost and market impact review on 2 provider transactions. So we'll provide just a brief overview of these 2 transactions. First was a proposed clinical affiliation between Lawrence General Hospital and Steward Healthcare. Under the proposed affiliation, LGH and Steward would engage in clinical collaboration for specialty hospital services, consider joint physician recruitment, and contemplate a network affiliation. Lawrence General is simultaneously ending its clinical affiliation with Beth Israel Lahey Health. This proposed affiliation, as filed with the HPC, was relatively narrow. Additional future collaborations, including potential joint commercial contracting or joint ventures, or even a corporate affiliation, of course, would require an additional new material change notice to the HPC for review. Given that in our preliminary examination, we found limited scope for spending or market impacts due to this transaction, we did not initiate a cost and market impact review, and we did not review evidence indicating the transaction is likely to negatively impact quality or access to care. Second, again, another clinical affiliation. This was between Atrius Health and Emerson Hospital, under which Emerson would be designated as a preferred facility for Atrius patients, and the parties would collaborate on care coordination, and Emerson would provide a discount on care provided at Emerson to Atrius risk patients. Here too, we found limited scope for spending impacts due to this clinical affiliation. Really, this affiliation formalizes an existing relationship between Atrius and Emerson, and we did not expect to see substantial changes in referral practices, patterns, or utilization as a result of this formalized agreement. And here too, we found no evidence or did not review evidence indicating negative impacts on quality or access to care. On the next slide is just an update of material change notices that are currently under review. The first 2 on this slide I will not go through, as we discussed them at the last board meeting. But since the last board meeting, we did receive 1 new material change notice, as indicated at the bottom of the slide. It is a proposed joint venture between Melrose Wakefield Healthcare, which is a community hospital subsidiary of Tufts Medicine, and Shields Healthcare Group. The joint venture would own and operate a licensed clinic to provide PET CT services to patients in the Melrose Wakefield service area. And this would replace a joint venture between Melrose Wakefield and Alliance Healthcare Services. So this review is currently, this notice is currently under review at this time. And then finally, as we discussed at the last board meeting, we're continuing to examine 2 other proposed changes in the pediatric market. First, Boston Children's Hospital has proposed establishing and expanding outpatient service sites outside of Boston. This plan is still under review by the Department of Public Health's Determination of Need program. And we expect that there will be an independent cost analysis released at some point in the future on this proposal. We're looking forward to reviewing that ICA when it becomes available. And then secondly, as discussed at the last meeting, Tufts Medical Center is proposing to close its pediatric inpatient beds and establish a new affiliation with Children's. Here, we expect that Tufts and Children's will be filing a material change notice regarding that proposed affiliation with the HPC. And we look forward to reviewing that transaction through our MCN review process.
David?
Yep.
Well, on the Tufts, it's not only a closure, but it's also a switching of those beds to the adult clinical side. So shouldn't the review have both sides to it?
So the determination of need, or the essential services program, is currently reviewing the closure of the beds and the transition of care to Children's Hospital Boston. We expect to receive from the HPC side, as I said, an MCN that really is focused on that relationship between Tufts Medical Center and Children's Hospital.
I don't think the conversion of beds within Tufts is the purview of HPC, but it's the purview of the Department of Public Health.
Yeah, was leading to that point. Thank you, Madam Secretary. So our purview really is around the new relationship, and so that will be something that we expect to review.
Okay.
And then finally, in our final minutes here today, just did want to provide a brief process update on the next slide regarding the Mass General Brigham Performance Improvement Plan. This slide shows all of the different steps in the Performance Improvement Plan process. This interactive roadmap is available on our website. As a reminder, we voted to require, the board voted to require a performance improvement plan in January of this year. Mass General filed its performance improvement plan proposal as expected on May 16th, and we shared those materials with all of you commissioners. And there is the public portion of their narrative is available on our website. Additionally, there are confidential elements which are also under our review. So since the proposal was submitted on May 16th, we as HPC staff have been closely reviewing the proposal along with our expert teams, and as permitted under our regulation, also consulting with other state agencies that have been identified in the plan. We have also been working directly with MGB as allowed in our regulation to make sure that all of the required material necessary to fully analyze the proposal and assess whether it meets the standards for approval have been filed with us, and that process and review is ongoing at this time. So we are not here today to vote on that performance improvement plan. On the next slide, just a little bit of a reminder of the standard for approval that the board will consider as we evaluate the MGB PIP. So as stated in our regulation, the board will approve the proposal if it finds that it is reasonably likely to address the underlying causes of MGB's cost growth, and that MGB will be capable of successfully implementing the plan in the 18-month period. In making that determination, as you can see in kind of the orange box here, there are other regulatory factors for consideration that the board may weigh, such as the scope and likelihood of the potential savings, the sustainability of the savings, et cetera. So we look forward to sharing more with you commissioners as we continue the review of the proposal and continue to learn more about the evidence base and the likelihood for success of the MGB PIP. So that is the extent of the update on the MGB PIP at this time, but I'm happy to answer questions on this as well as any of the market oversight changes previously reviewed.
Okay, thank you, David. Comments or questions by my fellow commissioners? So we look forward to the further discussion about the PIP improvement from Mass General Brigham at our next meeting. So
That's great. Just this slide, just to close out my executive director's report, is just a summary of some of our recently released publications and videos, and as well as a preview of some of the things that we expect to be working on over the next few months and releasing. So please always check out our website. We are continuously updating with new research reports, briefs, just a lot of really incredible work being documented there. And then finally, on the next slide, you can see our schedule of upcoming meetings. As you said, Chair Altman, our next board meeting is not that far away, just July 13th. So we will be back together in just a few short weeks for that board meeting. And want to wish commissioners a happy beginning of the summer. And let's go Celtics. And with that, I will turn it over to you, Chair Altman, to close out our meeting.
Yes, thank you for reminding me to tape the Celtics game tonight. Okay, any final comments or questions from my fellow commissioners? If not, it was great. We sort of got really good insights into two very good reports, and I look forward to our next meeting. So with that said, I will accept a motion to adjourn the meeting. Having heard everyone supporting that.